Okay, welcome to the deep dive. Today we are embarking on, well, a mission. A mission to go not just deep, but profoundly deep into the intricate world of the retina and the vitreous. These are, the critical structures at the back of your eye, absolutely essential for sight.
And our guide for this journey is a single, pretty comprehensive source. It's a medical text excerpt focused specifically on diseases of the retina and vitreous.
Right.
Think of this as our intensive training manual, if you will. Our goal here is to extract and really understand every significant piece of information presented.
Exactly.
We want to master this material with the kind of detail elite professionals would demand. We're leaving no stone unturned in these pages.
Exactly. This is about true mastery. We want to understand fundamental anatomy, every key pathological process, the specific clinical signs this text highlights, how diagnosis is approached within this material, and of course, the management strategies described. It's a lot, but we're going to tackle it systematically.
We'll start by establishing our baseline, the structure and function of the retina itself, really nailing down its key zones and features as described in the text.
Okay.
Then we'll systematically move through the categories of diseases presented, covering everything from, systemic connections to degenerations and detachments.
And finally, we'll shift our focus to the vitreous, its age-related changes, the problems that can arise within it, and the surgical interventions our source discusses for dealing with these pretty complex issues.
Right.
So buckle up. We're going to unpack this dense material and hopefully emerge with a solid understanding of what this vital source tells us.
Sounds like a plan.
Let's dive right into the retina then. Our source defines it as the neural layer at the back of the eye, the fundus, that actually enables vision.
Right, and it's remarkable that it's transparent itself. The color we see, that comes from the pigmentary layers and the vascular choroid behind it.
Ah, okay.
And the text gives us a breakdown of the retina into key anatomical zones, which is, crucial for precisely localizing any findings.
Makes sense.
We have the posterior retina, which is basically everything behind the equator. This is the part you examine with direct ophthalmoscopy or slit lamp indirect biomicroscopy.
And then moving forward, there's the peripheral retina, anterior to the equator. To get a good look at this, you typically need indirect ophthalmoscopy, or maybe a 3-mirror contact lens.
Now, arguably, the most critical zone for central vision is the macula lutea.
Right.
Our source describes this as the clinical posterior pole, an area roughly 5.5 millimeters in diameter, and it's just packed with cones.
And right in the heart of the macula is the fovea. This is a central 1.5 millimeter area located, about 2 disc diameters temporal to the optic disc. Why is this specific spot so important?
Well, the text makes it clear. The fovea is where we have the highest visual acuity.
Okay.
And this is because, uniquely in this area, only cones are present. And each cone has a direct one-to-one relay to a single ganglion cell.
Ah, a dedicated pathway.
Exactly. That dedicated pathway is key to sharp, detailed central vision.
Even smaller, within the fovea, is the foveola. Our source gives its diameter as about 0.35 millimeters.
Tiny.
Yeah. It's described as a central depression, appearing a deeper red, and often shows that bright foveal reflex light reflecting off the curved walls.
Exactly. And within this critical central zone, the text points out the foveal avascular zone, or FAZ.
Right.
This is a central area, maybe 0.4 to 0.6 millimeters across, that is completely free of retinal blood vessels.
And that lack of overlying vessels, that's another factor contributing to the maximal visual acuity here.
Precisely. Helps keep the pathway clear.
Shifting focus slightly to the blood supply. The retinal vessels originate from the central retinal artery and vein. They come into the eye through the optic nerve and branch out superiorly, inferiorly, temporally, and nasally.
And a distinct anatomical point highlighted by the source is how the temporal branches curve wide to sort of avoid the macula, while the nasal branches take a more radial path. And significantly, the text states that under normal conditions, there are no anastomoses, no connections between these retinal vessels.
That's interesting. So they're end arteries, essentially.
Pretty much, yeah. That's in contrast to the choroidal vessels, which lie beneath the retina. Our source describes them as broader, ribbon-like, and they do anastomose freely.
Okay.
They're usually transparent, but you can see them more easily, giving the fundus that tessellated look in individuals with less pigment, like albinos or those with high myopia.
Right, you see the underlying pattern. And the text gives us practical tips for distinguishing retinal arteries from veins during an ophthalmoscopic exam.
It does. Arteries are brighter red and narrower, often showing a bright silvery streak from light reflection off the surface of the blood column.
Ah, the blood column itself.
Yeah, because that's what you're seeing, the column of blood within the vessel.
Heh.
Veins are described as purplish, duller, and whiter.
And there's a fascinating physiological sign mentioned. Retinal venous pulsation. The source notes this can be observed near the optic disc in a large percentage of people, 80 to 90%.
Yeah, it's pretty common. This pulsation, the text explains, is caused by the interplay between intraocular pressure, IOP, and venous flow as the vein passes through the lamina cribrosa at the optic nerve head.
Oh.
Venous pressure is lowest at the disc. During each arterial systole, the IOP slightly rises, momentarily hindering venous outflow. The venous circulation then recovers during arterial diastole.
So it's a pulsation that occurs during the diastolic phase of the arterial pulse. That's why the text calls it a negative venous pulse.
Exactly. And interestingly, it notes you can sometimes induce this pulsation by applying slight pressure to the globe.
Moving towards the edge of the retina now. The ora serrata marks the anterior termination of both the choroid and the retina.
Right. It's described as appearing gray to brownish black. And the source emphasizes that the vitreous base, that's the anterior attachment of the vitreous gel, is very firmly attached right here, straddling the ora serrata.
That's a key point for later, I imagine, with detachments.
Absolutely. Critical attachment point.
Okay, so when the retina is affected by disease, our source lists a spectrum of potential symptoms you might experience. Diminished visual acuity is a common one, obviously.
Blurry vision.
Concentric field constriction, where your peripheral vision narrows. Or scotomata, which are blind spots corresponding to the damaged areas.
Right. Specific areas of vision loss. Other potential symptoms include metamorphopsia, where straight lines appear distorted or wavy.
Like looking through water.
Yeah, exactly. Or micropsia, seeing objects as smaller than they are, or micropsia, seeing them as larger. Reduced contrast sensitivity is also noted, particularly if the pathology involves the macula.
And the text even references the value of a retinal diagram, like figure 17.1, as a tool for precisely mapping and recording various lesions, holes, tears, new vessels, hemorrhages, exudate.
Absolutely. Using that diagram is fundamental to clinical practice, allowing for precise documentation of findings described in the text. It's like a map of the battlefield.
Okay, with that essential anatomical foundation from our source, let's transition into the diseases. The text begins with the systemic vascular retinopathies, explicitly stating these occur as part of systemic disorders, like hypertension, diabetes, and late toxemia of pregnancy.
And the source makes a crucial point here. The state of the retinal vasculature in these conditions often mirrors the vascular status elsewhere in the body, including the brain.
So the eye is a window to systemic health.
Very much so. The underlying mechanism suggested is likely anoxia, lack of oxygen, leading to increased capillary permeability, microaneurysms, and subsequent degeneration.
The text highlights two major ophthalmoscopic manifestations that are key to recognizing these conditions. First, soft exudates, also commonly called cotton wool patches.
Right. And our source explains these aren't actually exudates in the traditional sense. They're swelling of nerve fibers in the superficial retina.
Oh, okay.
It's due to the arrest of axoplasmic flow at the edge of an ischemic area. They appear as fluffy, cloud-like patches with ill-defined margins, often found around the optic nerve head.
And they can change quickly.
Yeah, the text notes they can disappear relatively rapidly and change shape. They're quite dynamic.
The other key manifestation is hard exudates.
These are distinctly different. The source describes them as resulting from the extravasation of fluid, specifically fluid rich in fibrin and proteins, which then deposits lipids.
So actual deposits.
Actual deposits, yeah. They're characterized by their well-defined margins, bright yellow, waxy appearance, and hyaline or lipid composition. They tend to cluster around leaking microaneurysms.
And as the text points out, when these hard exudates occur in the macula, they can arrange themselves radially around the foveal center,
Right.
following the orientation of the Henle fiber layer. This distinct pattern is referred to as a macular fan or macular star.
Exactly, a very characteristic sign. The source then goes deep into hypertensive retinopathy, describing its presentation under 4 different clinical scenarios.
Okay, reflecting the varied impact depending on age and vascular sclerosis.
Right. First, simple hypertension without sclerosis, typically seen in younger patients. The text describes few retinal signs here. mainly generalized constriction of the retinal arterioles.
So they look narrower.
Yeah, narrower, pale, straight with acute branching. You might also see superficial flame-shaped hemorrhages and cotton wool spots, but importantly, the source notes the absence of hard exudates in this specific scenario.
Got it. Second scenario.
Second is hypertension with involutionary sclerosis found in older patients. Here, you see the combined picture of high blood pressure and age-related artery hardening.
Makes sense.
Beyond the signs of simple hypertension, the text points to localized constrictions and dilatations of the vessels, thickening of the vessel walls, hard exudates, and sometimes hemorrhages, but often without significant edema.
And the key diagnostic feature here.
The absolutely diagnostic feature highlighted is the arteriovenous crossing changes.
AV nicking.
Yeah, AV nicking or nipping, where a sclerotic artery crosses over a vein, causing the vein to look narrowed at the crossing or even deflected perpendicularly. That's known as the gun sign.
Okay.
These changes are bilateral, but the source mentions the retinopathy can occasionally be unilateral if there's significant carotid artery insufficiency on one side, reducing pressure to that eye.
Interesting. What's the third circumstance?
The third is arteriolar diffuse hyperplastic sclerosis, typically in younger patients experiencing severe chronic hypertension. The text explains this involves proliferative and fibrous changes occurring in the media of the relatively young arterioles in response to the high pressure.
So the vessels are reacting to the pressure.
Exactly. This is often the retinopathy seen with chronic glomerulonephritis, sometimes called albuminuric or renal retinopathy.
Yeah.
The vessels are narrow and tortuous with marked nicking. Multiple hemorrhages are common. Early features include edema and cotton wool patches, progressing later to diffuse hard exudates, often forming that macular star.
Can it get better?
The text notes that if the patient survives the underlying renal disease, the fundus changes can regress, but vision may remain seriously impaired due to the damage.
Okay. And the fourth scenario.
The fourth is malignant hypertension, described as an accelerated and severe form occurring in patients, often younger, whose arteries haven't yet undergone extensive age-related changes. It's closely associated with renal insufficiency.
And the eye findings are dramatic.
Very. Characterized as hypertensive neuroretinopathy and dominated by edema. The text paints a striking picture. Generalized retinal edema, often pronounced disc edema, papilledema.
Swelling of the optic nerve head.
Right. Multiple cotton wool patches and incredibly profuse hard exudates, sometimes forming enormous masses, with a very prominent macular star. Vision is usually severely affected.
Sounds grim.
The source emphasizes the prognosis is grave unless the blood pressure is rapidly controlled. While treatment can lead to dramatic improvement in the eye findings and vision, the text cautions that the ultimate visual prognosis, despite amelioration, is often unsatisfactory due to irreversible damage.
Our source references the Keith, Wagner, and Barker classification from 1939, noting it's still used.
Yeah, it grades hypertensive retinopathy from 1 to 4 based on ophthalmoscopic features, which correlates with the severity of hypertension and, importantly, inversely with survival prognosis.
So grade 1 is mild narrowing sclerosis.
Right. Grade 2 shows moderate narrowing, exaggerated light reflex, and definitive AV crossing changes.
Okay.
Grade 3 adds narrowing with focal constrictions, prominent AV changes, and signs of vascular leakage like retinal edema, cotton wool spots, and flame-shaped hemorrhages.
And grade 4 is grade 3 plus the critical finding of papilledema, the disc swelling.
Exactly. The text does acknowledge there can be some difficulty in consistently defining the criteria for grades 1 and 2 sometimes.
Okay. Transitioning now to diabetic retinopathy. Our source highlights diabetes as a very common disease, type 1 and type 2, known to cause both macro and microvascular complications.
Right. And the text specifies that the microvascular complications affecting the kidneys, eyes, and peripheral nerves are strongly linked to the level of glycemic control.
So blood sugar matters a lot for those.
Definitely. Macrovascular complications affecting the heart, brain, and limbs are more common, but not necessarily tied as directly to hyperglycemia levels, according to this source.
While there's a characteristic fundus picture in diabetic retinopathy, the source notes that in older patients, it can be complicated by coexisting arteriosclerosis or hypertension.
Yeah, making the diagnosis sometimes challenging. And it states nearly all type 1 diabetics will develop retinopathy within about 15 years of onset. It's almost inevitable over time.
The key risk factors listed. Duration of diabetes is a big one.
Huge. The longer you've had it, the higher the risk. Also accompanying systemic hypertension and smoking.
And the statistics presented are stark. Diabetics have a 20 to 25 times higher risk of blindness.
Yeah, compared to the non-diabetic population, it really underscores the absolute importance the source places on regular annual screening for all diabetic patients via a dilated fundus examination.
Early detection for early therapy.
Exactly. And strict glycemic control is also heavily emphasized as a key factor in helping to stabilize retinal changes.
The text details the pathogenesis at a microscopic level. Loss of intramural parasites.
Yeah, those are supportive cells in the capillary walls. Also, thickening of the basement membrane surrounding the capillaries and progressive closure of retinal capillaries.
And the loss of parasites leads to.
That leads to vascular dilations, which we see clinically as microaneurysms. Then the breakdown of the blood-retinal barrier allows leakage of fluid and plasma constituents into the retinal tissue.
Causing edema and hard exudates.
Right. And small, deep hemorrhages, termed dot and blot hemorrhages, also occur. Increased platelet aggregation contributes to capillary non-perfusion, leading to retinal ischemia areas starved of oxygen.
So the body tries to fix this.
It tries. In an attempt to reestablish blood flow to these ischemic areas, the body initiates revascularization. This can manifest as shunt vessels, referred to as intraretinal microvascular abnormalities, or IRMA.
Okay.
It also leads to the elaboration of vasoproliferative substances, notably vascular endothelial growth factor, or VEGF.
VEGF, that's a key player.
A major player. It drives the growth of new abnormal blood vessels neovascularization.
And these new vessels are problematic.
Very. The text points out they're fragile and bleed easily. Their growth is often accompanied by fibrovascular tissue, which can exert traction on the retina.
Pulling on it.
Yeah. While the precise causal factors remain unclear, the source reiterates the known risk factors. Poor glycemic control, duration of diabetes, uncontrolled hypertension, poor renal status, and smoking.
The earliest clinically recognizable stage described is background diabetic retinopathy, also known as non-proliferative.
Right. This stage primarily affects the smaller vessels. Characteristic signs, as detailed in the text, include dot and blot hemorrhages and microaneurysms.
Microaneurysms look like little red dots.
Minute round dots, yeah, sometimes appearing in clusters like grapes. Hard exudates, those waxy, well-defined deposits, are also present and can coalesce into larger plaques.
And there's a link to kidney disease here.
The source notes that this fully developed background picture, particularly with microaneurysms, is frequently associated with Kimmel-Steele-Wilson nephropathy in the kidneys, highlighting that systemic connection.
Management for this stage. Good metabolic control is key.
Absolutely. Plus managing any coexisting renal problems or systemic hypertension. The ETDRS scale is mentioned as the standard for classifying the severity of non-proliferative retinopathy, providing a standardized definition from no retinopathy up to severe non-proliferative.
Okay. Diabetic maculopathy is specifically identified as the single commonest cause of vision diminution in diabetic retinopathy.
Right. It arises from leakage from dilated capillaries in the macular region, leading to macular edema and the deposition of central hard exudates.
And the text defines clinically significant macular edema, or CSME.
It does. It's defined by the presence of edema or hard exudates located within 500 microns of the foveal center.
Okay.
Or if the edema extends over an area larger than one disc area, any part of which is within one disc diameter of the foveal center. Leakage can be either focal from discrete points or more diffuse.
Ischemic maculopathy is also described.
Yeah.
Lack of blood flow to the macula.
Yeah, resulting from capillary non-perfusion. Often, the source notes a mixed picture of both edema and ischemia is present. Symptoms can range from a noticeable decrease in vision to surprisingly normal visual acuity despite the changes.
How do you spot it?
Clinical recognition is best achieved with slit lamp biomicroscopy using specific high-plus lenses, like a +78 or +90 diopter lens. The signs to look for, according to the text, include a loss of the normal foveal reflex and visible thickening of the retina around the macula.
And treatment involves laser. Photocoagulation.
Primarily, yes, using argon, diode, or YG lasers. Fluorescein angiography is essential here to map the areas of leakage.
Okay.
If the leakage is focal from discrete microaneurysms, these points are targeted directly with laser. If the maculopathy is diffuse, a grid pattern of light burns is applied over the posterior pole, taking care to avoid the central foveolovascular zone.
But laser isn't helpful for ischemic maculopathy.
Correct. The text explicitly states that fluorescein angiography is also used to diagnose ischemic maculopathy, where laser is not helpful and should be avoided.
The source source adds that intravitreal injections of steroids or anti-VEGF agents are also utilized for diabetic macular edema.
Right, either as a standalone therapy or in combination with photocoagulation.
Sursonate retinopathy. This is a distinct pattern.
Yeah, associated with chronic edema and significant retinal changes around the macula. Often seen in elderly patients, can be part of diabetic or hypertensive retinopathy.
What does this look like?
Its characteristic appearance is a girdle of bright white, hard exudates. The text explains these are aggregations of macrophages engorged with lipids.
Okay.
This band often forms an imperfect circle, ellipse, or horseshoe shape, typically open towards the temporal side. It's usually larger than 1 disc diameter in size and tends to follow the course of the larger temporal vessels.
Treatment involves finding the leak.
Trying to, yeah. Localize and destroy the source of the vascular leakage responsible for the exudates using photocoagulation. Intravitreal steroids and anti-VEGF agents are listed as alternative therapeutic options for the associated diabetic macular edema.
Advancing from background retinopathy, we come to severe non-proliferative or pre-proliferative diabetic retinopathy. This stage signifies ischemic changes are now superimposed.
Exactly. The fundus picture at this stage, according to the source, shows the presence of IRMA, those shunt vessels we discussed earlier, and compelling evidence of significant ischemia, often quantified by the presence of more than 8 to 10 cotton wool spots. Dilated and irregular veins, along with attenuated arterioles, are also present. The text highlights that these changes indicate high risk for progression to the next, more severe stage.
So close monitoring is needed.
Absolutely. The source strongly emphasizes the need for frequent review, often accompanied by fluorescein angiography, to monitor for early signs of neovascularization. Photocoagulation should be initiated, the text advises, at the very first sign of new vessel formation.
And if follow-up is tricky?
Then the text recommends proceeding with panretinal photocoagulation even at this pre-proliferative stage if reliable follow-up isn't possible.
Proliferative diabetic retinopathy. This is the most severe form.
Yes, potentially devastating. The source states that approximately 2/3 of type 1 diabetics will develop this stage over 3 decades. It's characterized by neovascularization, the growth of new abnormal blood vessels.
Where do they grow?
They can arise from the optic nerve head itself, termed NVD, neovascularization of the disc, or along the large retinal vessels or elsewhere in the retina, termed NVE, neovascularization elsewhere.
What?
These new vessels almost always form adjacent to areas of capillary closure and ischemia.
And they bring scar tissue with them.
Critically, yes. The text notes that fibrovascular tissue accompanies these new vessels. This tissue can lie flat on the retinal surface or, more dangerously, attached to the posterior vitreous face.
And as it contracts.
It exerts traction on the retina, potentially leading to retinal separation and tearing of the fragile new vessels. The source explicitly states this is the commonest cause of spontaneous vitreous hemorrhage in adults.
Wow. Can it affect the front of the eye too?
Yes, the proliferation can also extend into the anterior segment, leading to neovascularization of the iris, rubeosus iridis, and the angle, which can cause refractory neovascular glaucoma, a very difficult condition to treat.
The primary treatment for proliferative diabetic retinopathy, as detailed in the text, is photocoagulation of the peripheral ischemic areas of the retina. Panretinal photocoagulation, or PRP.
Right. The goals of this extensive laser treatment are multifaceted. Reduce the metabolic demand of the ischemic retina, decrease the production of vasoproliferative factors like VEGF.
Starve the stimulus?
Kind of, yeah. By converting hypoxic areas to anoxic foci, and also to induce scarring that obliterates the fragile new vessels and seals any leaking vascular anomalies.
So it helps relieve edema, causes vessel regression, inhibits hemorrhages.
Exactly. The source identifies high-risk eyes defined by having significant NVD, significant NVE, or the presence of vitreous hemorrhage as requiring urgent PRP.
The text gives quite specific details on the PRP technique. Lots of laser burns.
Yeah, it involves using a retinal laser lens to apply numerous burns in a circular area, leaving the central fovea untreated. Burns are applied outside the main vascular arcades, extending all the way to the equator.
How many burns are we talking?
Typically between 2,000 and 3,000 burns per eye, delivered over 2 to 4 sessions. They're aimed at the RPE to cause blanching, effectively obliterating the deeper retinal layers in that spot.
And the results.
The source reports long-term visual results are most encouraging for eyes with significant NVD. Rubeosus iridis usually regresses after successful laser. However, neovascular glaucoma and tractional retinal detachment remain major causes of ultimate visual failure despite treatment.
So it's not always a permanent fix.
No, repeated photocoagulation may be necessary for recurrence.
Adjunctive medical therapies are also mentioned, anti-VEGF agents.
Right, specifically naming bevacizumab, ranibizumab, and aflibercept. They're used alongside photocoagulation, allowing for greater success in controlling neovascularization. Intravitreal triamcinolone, a steroid, is also mentioned as having been evaluated for diabetic macular edema.
For the most advanced stages, tractional detachment or non-clearing vitreous hemorrhage. Surgery is the way to go.
Vitreoretinal surgery is presented as the treatment of choice, then yes. The text highlights that early vitrectomy surgical removal of the vitreous gel is considered more beneficial, particularly for type 1 diabetics who are typically younger and more prone to aggressive PDR.
Why remove the vitreous?
It acts as a scaffold and support for new vessels and fibrovascular tissue. Removing it helps prevent further neovascularization. Tractional detachment itself is treated during surgery by excising the fibrovascular tissue, sealing any resulting retinal breaks with laser, and using internal tamponade to hold the retina in place.
Okay. Finally, under diabetic retinopathy, our source describes leukemia retinalis.
Yeah, this unique and peculiar finding. A striking ophthalmoscopic picture seen in young patients with extremely high levels of triglycerides.
Over 2,000.
Yeah, typically exceeding 2,000 millig 100 millil, often associated with growth-onset diabetes and marked acidosis. The appearance of the retinal vessels is milky or creamy white.
Wow.
The text notes arteries appear pale red, veins have a slight violet tint, though the general color of the fundus remains relatively normal.
Okay, let's move on to retinopathy of prematurity, or ROP. Our source describes this condition occurring in premature infants, usually weeks after birth.
Right. Primarily affecting babies with a birth weight less than 1.5 kilograms and/or a gestational age less than 32 weeks, and it's strongly associated with exposure to high concentrations of oxygen in the neonatal period.
Usually both eyes.
Typically affects both eyes, yeah, although the severity can vary between them. The pathogenesis, as explained by the text, relates to the fact that the retina is incompletely vascularized at birth.
Especially the periphery.
Exactly. The temporal periphery is the last area to complete vascular development, usually a month or so after full term. These immature retinal vessels are vulnerable to damage from oxygen.
So high oxygen causes vasoconstriction.
And subsequently, obliteration of small arteries and veins. This is then followed by a phase of neovascularization where abnormal new vessels grow.
In scar tissue forms.
Right.
The proliferation and subsequent contraction of fibrovascular tissue that develops around these shunt areas explains the progressive changes seen in ROP. The retinal detachments that occur are typically tractional, pulled off by this contracting tissue.
The source details the progression. Early signs like dilated veins, white patches.
Yeah, earliest signs include dilatation of retinal veins and hazy white patches appearing in the peripheral retina. This progresses to proliferation into the vitreous as new vessels bud off. Development of fibrous tissue can follow, potentially forming a continuous mass behind the lens, sometimes resembling a pseudoglioma.
And it can either stop or progress.
Right. The text indicates the activity can either cease spontaneously, allowing the infant to retain some vision, or it can relentlessly progress to significant retinal detachment and potentially a microphthalmic or small underdeveloped eye.
The source outlines the new international classification of ROP 5 stages.
Yes, stage 1 is a simple demarcation line between vascular and avascular retina. Stage 2 involves an elevated ridge at this boundary.
Stage 3 marks the appearance of fibrovascular tissue and extraretinal neovascularization extending into the vitreous, accompanied by tortuous dilated vessels posteriorly and often hemorrhages.
Stage 4.
Stage 4 is tractional retinal detachment extending from the periphery towards the posterior pole. Stage 5 represents total retinal detachment.
The classification also includes plus disease. What's that?
That's a critical sign indicating progressive vascular incompetence. It's characterized by prominent tortuous arteries and dilated veins in the posterior pole.
So it means things are active and progressing fast.
Exactly. It signifies activity and high potential for rapid progression.
Regarding prognosis, the source offers some optimism. 80% resolve spontaneously.
Yeah, particularly the milder stages, with complete and normal retinal vascularization. However, the remaining cases can develop significant sequelae.
Like high myopia, fibrosis, detachment.
Right. Myopia, temporal vitreoretinal fibrosis with associated disc dragging, retrolental fibrovascular tissue, secondary angle closure glaucoma, and ultimately total retinal detachment. The term retrolental fibroplasia is reserved specifically for the non-acute late scarring changes behind the lens.
Management places the highest importance on prophylaxis and early detection. Screening is key.
Absolutely. Screening premature babies meeting the weight or gestational age criteria with indirect ophthalmoscopy is crucial, typically between 32 and 36 weeks post-conceptional age. Monitoring PaO2 levels in the very low birth weight infants is also mentioned.
And checking for threshold disease before discharge.
Yes. The text stresses examining the temporal periphery specifically for threshold disease, defined by the ridge, significant extraretinal proliferation, and plus disease signs posteriorly.
If minor signs are present, just watch closely.
Right. Repeat exams at regular intervals to monitor for early holes or detachment. Treatment using photocoagulation or cryotherapy to the vascular periphery is only considered with definite progressive plus disease or bilateral proliferative lesions extending into the vitreous.
Delay treatment if it's mild.
The text advises delaying treatment with mild intravitreal neovascularization due to the high spontaneous resolution rate. However, once ROP reaches the fully developed advanced stages, the prognosis becomes very poor and treatment is relatively ineffective. Surgery is rarely helpful then. The role of anti-VEGF is noted as under evaluation.
Okay. The source briefly mentions retinal manifestations in AIDS. Cotton wool spots are common.
Yeah, observed in about 50% of patients. The text notes their exact cause is uncertain, but suggests they are likely directly related to the HIV virus itself.
And patients are prone to opportunistic infections affecting the retina.
Absolutely. Cytomegalovirus, toxoplasma, herpes viruses, those are key concerns.
Retinopathy and toxemia of pregnancies. This happens late in gestation.
Almost exclusively in the 9th month, the source says, though exceptionally earlier. It shares many characteristics with severe hypertensive retinopathy.
What are the signs?
Initial signs involve narrowing of the retinal arteries, often starting nasally, followed by noticeable spasmodic contractions. As blood pressure rises, significant retinal edema appears, resembling marked hypertensive retinopathy.
Can it cause detachment?
Yes, the source points out that the exudation in severe cases can be so profuse it leads to severe retinal detachment. A unique responsibility for the ophthalmologist, according to the text, is to investigate any visual symptoms late in pregnancy, as arterial constriction spasms plus weight gain are ominous signs.
And the advent of retinopathy is serious.
Very. It's presented as a strong indication to consider termination of the pregnancy due to risks to the mother's vision and life and the fetus. However, the text also notes that timely induction and good medical care can often lead to recovery and resolution of the retinal changes, including detachment resolution if gross organic changes haven't occurred.
Similar to pheochromocytoma retinopathy.
Right. The source draws that parallel, noting similar reversible features if the underlying tumor is dealt with early.
Finally, under systemic vascular retinopathies, sickle cell retinopathy, associated with abnormal hemoglobin.
Primarily of African origin, yeah. The text explains deoxygenated sickle hemoglobin distorts red cells into a sickle shape, obstructing capillaries, especially peripherally, leading to infarction tissue death.
And sickle cell C disease, HBSC, is most important ophthalmologically.
That's what the source highlights, due to its predominantly ocular manifestations, which include things like angioid streaks beyond just the retinopathy. Pathogenesis involves specific amino acid substitutions. SC disease patients lack the normal beta chain gene.
Fundus changes, non-proliferative and proliferative.
Right. Non-proliferative includes peripheral arterial occlusion. Proliferative involves neovascularization and vitreous hemorrhage. The fibrovascular proliferation can form distinct C-fans, often superotemporally.
Other signs.
Vascular tortuosity, CRAO, CRVO, angioid streaks, sunburst spots from old hemorrhages, optic atrophy. Late complication is retinal detachment from vitreous traction.
Treatment is laser.
Sector photocoagulation aims to cause regression of the neovascular lesions. Vitreoretinal surgery may be needed for detachments, but the source notes a significant risk of anterior segment necrosis post-op in these eyes.
Okay, now let's shift focus specifically to vascular disorders of the retina involving obstruction or occlusion.
Right. Complete or partial, permanent or temporary blockages. Arterial obstruction is usually caused by an embolus, a plug traveling in the bloodstream.
Often from the carotid or heart.
Yeah. The text mentions emboli often originate from an atheroma plaque at the carotid bifurcation or diseased heart valve. Superadded spasm often completes the occlusion. It can happen even without general vascular disease, but is more common with arteriosclerosis, hypertension, etc.
Central retinal artery occlusion, CRAO. That's the big one.
Yeah, blockage of the central retinal artery itself, usually at or just behind the lamina cribrosa. This causes sudden, complete ischemia of the entire inner retina.
Leading to sudden blindness.
Sudden, profound blindness. Patients might have premonitory transient obscurations if small emboli were occurring before.
What does it look like?
Ophthalmoscopically, very characteristic. Larger arteries are visibly narrowed like thin threads, smaller ones often invisible. Veins initially little altered. Within hours, the retina becomes opaque and milky white, especially near the disc and macula.
And the cherry red spot.
That's the pathognomonic sign. The thin foveola stays relatively transparent, allowing the underlying red choroid to show through, contrasting sharply with the pale, opaque background.
What if the obstruction is incomplete?
Partial flow might be restored in days. Applying gentle globe pressure might cause the venous blood column to break up the cattle truck or boxcar appearance. Easy vein emptying or arterial pulsation with slight pressure also suggest incomplete blockage.
Does the retina stay white?
No, the white opaque appearance clears over weeks as edema subsides. But the text stresses the inner retina is now profoundly atrophic. Outer layers survive via choroidal nourishment. Vessels become contracted, white threads, maybe some refilling via collaterals later. Disc becomes atrophic, no direct pupil reaction, light perception lost.
But sometimes central vision persists.
Yes, if the macula is supplied by a ciliaretinal artery from the ciliary circulation, escaping the occlusion, or if a macular branch comes off proximal to the block, the rest of the field is lost though. Isolated ciliaretinal artery block is rare.
Branch retinal artery occlusion, BRAO, just affects one sector.
Right, only the area supplied by that branch results in a visual field defect, a scotoma that becomes a permanent sector shape.
Treatment for arterial occlusions, often not helpful.
Unfortunately, seldom helps once complete and present for more than a few hours. Early attempts in the first critical hours include vigorously massaging the globe, most effective early measure per the text, paracentesis to lower IOP, inhaling amyl nitrite for vasodilation. Must be done immediately. Normal outcome of complete CRAO is irreversible blindness.
Okay, let's look at obstruction of venous circulation. First, venous stasis retinopathy.
Right. Presented as a well-defined entity, typically in young, healthy adults, 20 to 40. Unilateral disc edema, variable vascular changes.
Symptoms are vague.
Often vague, unilateral fogginess. Ophthalmoscopically can range from minimal changes to markedly engorged, dilated, tortuous veins with hemorrhages mainly posterior. Crucially, visual acuity stays good and there's never vitreous hemorrhage.
And tests.
Neuroexam is negative. Fluorescein angiography confirms venous stasis, delayed drainage, generally no permanent visual defect. Steroids occasionally used, but safe to just follow healthy young adults if no other findings. Withholding steroids unless macular edema is causing vision loss.
So it mimics a clot, but isn't ischemic.
Exactly. Simulates central venous thrombosis, but fundamentally different due to absence of retinal ischemia. Cause unknown, maybe phlebitis of the central vein.
True venous thrombosis or occlusion usually occurs in older folks.
Yes, with cardiovascular disease or chronic glaucoma. Obstruction typically happens either in the central vein behind the lamina cribrosa, affected by arterial sclerosis in the shared sheath, or peripherally in a branch vein, often at a bifurcation, or where a sclerosed artery crosses the vein. Superior temporal vein occlusion is common.
Can happen in younger people.
Yeah,
Yeah.
sometimes due to infective paraphlebitis. Local causes include glaucoma, orbital cellulitis, facial erysipelas. The source flags venous thrombosis as a danger signal needing systemic investigation.
Central retinal vein occlusion, CRVO.
Yeah.
The main vein blocked. What's the picture?
All retinal veins enormously engorged, extremely tortuous, entire retina covered with extensive hemorrhages, sight severely impaired, though not as rapidly as CRAO.
Any new vessels?
Often, yes. Tortuous new vessels on the disc, or collateral circulation via new vessels in the retina itself. Eventually, the affected retina becomes atrophic with fine pigment changes.
What's the big risk here?
A significant factor worsening prognosis is secondary neovascular glaucoma, developing in 2-3 months due to widespread neovascularization in the angle.
Branch retinal vein occlusion, BRVO.
Yeah.
Just one branch blocked.
Right. Edema and hemorrhages limited to the area supplied by that branch. Visual defect is partial, not always perfectly sectorial. Prognosis for central vision generally better than CRVO, but superior temporal vein blockage often involves the macula.
Angiography helps predict outcome.
Yes, the source states eyes with intact parafoveal capillary arcades on angiography tend to have better visual prognosis. Secondary glaucoma is rare in BRVO.
Treatment for venous occlusions. Can't unblock it.
No effective treatment once blockage is complete, but treatment is directed at complications. In cases of widespread capillary occlusion, cottonwool spots, delayed transit, leakage, edema, pan-photocoagulation or cryo can be used to try and prevent neovascular glaucoma and rubiosis.
And for branch occlusion.
Photocoagulation targeting areas of poor perfusion, guided by angiogram, may help relieve persistent macular edema and inhibit neovascularization. Key point. Photocoagulation should not be done until the intraretinal blood has largely absorbed.
Anti-VEGF is used here too.
Yes, intravitreal anti-VEGF injections are specifically listed as an established treatment aimed at improving visual recovery, reducing edema, and preventing late complications like neovascularization.
Okay. Coats disease. Characteristic monocular picture.
Yeah, typically in boys, otherwise healthy. Large, raised areas of yellowish-white exudation, often posterior to vessels, frequently leading to detachment. Late stages, cataract, glaucoma.
What's going on underneath?
Microscopic exam always shows hemorrhage deep in retinochoroid. Ophthalmoscopically, small aneurysms and varying exudation, maybe cholesterol crystals. Choroid initially healthy. Source compares it to angiomatosis. Early recognition plus prophylactic laser cryo beneficial.
Under medical therapy and retinal vascular disease, the source reiterates retinal ischemia drives neovascularization and edema.
Yes, in diabetic retinopathy venous occlusions, also neovascular ARMD, ROP, photocoagulation is the standard but has side effects. Ischemia releases proangiogenic factors, especially VEGF.
So anti-VEGF helps.
Adjunctive anti-VEGF agents, pegeptinib, bevacizumab, ranibizumab, aflibercept, highlighted as successfully used, particularly for neovascular ARMD and diabetic retinopathy, allowing greater success in control.
Steroids, too, for edema.
Right. Mechanism involves downregulating inflammation, modulating VEGF gene response, intravitreal triamcinolone listed as evaluated for DMO, cystoid macular edema, venous occlusion, Eales disease, sustained release implants, dexamethasone, fluocinolone, also noted as available.
Let's shift now to inflammation of the retina, retinitis.
Yeah.
Our source points out it's usually chorioretinitis.
Right. Inflammation limited solely to the retina is rare. Usually involves the choroid too. Can be purulent or specific infections. Treatment targets the underlying general condition.
Purulent retinitis, acute infections.
Yeah, can occur in pyemia, leading to metastatic endophthalmitis or panophthalmitis. Subacute infective retinitis, or septic retinitis of Roth, occurs in less virulent metastatic infections like bacterial endocarditis or puerperal septicemia.
Where does it affect?
Typically the posterior fundus, characterized by recurrent hemorrhages, embolic, some with white centers. The characteristic finding is Roth spots, round oval white spots, little general retinal reaction, maybe some edema, papilledema, often fatal, vision seriously impaired if survived.
Endophthalmitis, infection inside the eye.
Defined as infection inside the eye, yes. Very serious, often results in significant vision loss or eye loss. Most commonly follows surgery or penetrating injury.
Treatment is aggressive antibiotics.
Aggressive antibiotics. 4. Drops, periocular, intravitreal. Severe cases not responding vitrectomy to remove infectious material, decrease bacterial load, improve antibiotic contact. Prognosis guarded, severe loss if not treated early.
Acute retinal necrosis, ARN syndrome. Sounds bad.
It is severe inflammation, blurred vision, panuveitis, peripheral posterior retinal whitening, multifocal coalescent, hemorrhages, vasculitis, artery vein. 2/3 unilateral initially.
Big complication is detachment.
Major complication. Retinal detachment in 75%, typically within 3 months. Caused by holes in necrotic retina plus vitreous traction. Source identifies herpes zoster simplex viruses as causes. Most patients get immunocompetent. Force cyclover helps lesions progress.
Cytomegalovirus, CMV
correct.
infection, seen in immunocompromised.
Mostly, yes. Manifests with impaired immune function, transplant, PAPS, AIDS, eye, isolated macular lesion, or severe hemorrhagic granular retinitis.
Syphilis affecting the retina, usually secondary to choroiditis.
Yes. Primary retinal changes often ill-defined. Congenital syphilis, characteristic pepper and salt fundus peripherally, often with interstitial keratitis.
acquired syphilis.
Endarteritis prominent, whitish exudates along vessels, diffuse retinitis in secondary stage, gray cloudy central retina, severe vitritis, subsides to typical picture, atrophic disc, consecutive optic atrophy, attenuated vessels, depigmented retina, bone corpuscle pigment aggregates peripherally, symptoms, poor central vision, night blindness, field contractions, scutum metamorphopsia. Treatment is for neurosyphilis, sarcoidosis, systemic granulomatous disease.
Right. Epithelioid cell granuloma, no caseation, affects lymph nodes, lungs, liver, spleen, skin, eyes, parotid, labs. High ESR, leukopenia, disturbed albumin globulin ratio, high ACE, maybe hypercalcemia, tuberculin negative, chest x-ray often shows bilateral Hiller nodes.
Ocular manifestations, widespread retinopathy.
Can be. Canned wax exudates along vessels, small whitish granulomata, optic nerve head edema or nodular granulomata atrophy, chorioretinitis patches, paraphlebitis, posterior uveitis. A 25% acular sarcoid peaks show posterior segment involvement. Retinal involvement often associated with CNS affection.
Toxoplasmosis, referred elsewhere.
Toxicariasis,
Yeah.
roundworm larvae.
Visceral larva migrants, yeah. Toxicaric aniscati. Children ingest eggs, hatch larvae penetrate, gut migrate. Heavy systemic infection causes symptoms, but larvae can lodge an eye without systemic signs.
What's the eye lesion?
Primary ocular lesion is an intraocular granuloma, white lesion protruding from retina. Histology, eosinophils, IgE, often larvae inside. Sometimes endophthalmitis. Diagnosis, rising antibody titers, ELISA. No eggs in stool.
Treatment.
Vitritis responds to topical steroids, supported by thiabendazole, systemic steroids. Tractional detachment, common surgery. Ascaris lumbricoides, also mentioned. Paraphlebitis retinae, inflammation of veins.
Relatively common, yes. Progressive peripheral ischemia, new vessel proliferation, the run is repeated. Vitreous hemorrhages. Typically healthy young adult males, often called Eels disease. Idiopathic, but source mentions possible link to hypersensitivity to tuberculoproteins, causing vasculitis. Peripheral vasculitis, obliteration, hypoxia, visual proliferation. Clinically see sheathing, leaks on angiography, hemorrhages, soft exudates at border zones, later. Vessel obliteration, AV shunts, neovascularization. Recurrent vitreous hemorrhage is the hallmark. Treatment.
Systemic steroids, early vasculitis, photocoagulation, abnormal vessels under traction, vitreoretinal surgery, marked traction-threatening macula.
Retinitis from bright light, photoretinitis, eclipse viewing.
Yeah, eclipse without protection, strong electrical flash, even operating microscope light. Visible, UV infrared rays absorbed by RPE, heating effect, burn, typically paramacular. Persistent after-image, positive scotoma, metamorphopsia. Ophthalmoscopy. Maybe nothing initially. Or pale spot at fovea with brownish red ring later. Pigment deposits, gray spots, maybe macular hole.
Prognosis. Treatment.
Guarded. Improvement often, some defect persists. Scotoma permanent. No effective treatment once damage done. Light-induced maculopathy from operating microscope is specifically noted post-cataract surgery. Oval, yellow-white area, mottled pigmented, often spares foveola central vision okay, but paracentral scotoma.
Okay, let's move now to degenerations of the retina, starting with myopic chorioretinal degeneration.
Associated with pathological myopia, 6D, long axial length. Features can include parapupillary atrophy, temporal crescent, macular atrophy, Foster's spot, lacquer cracks, lattice degeneration, diffuse chorioretinal atrophy, various combos.
Age-related macular degeneration, ARMD, leading cause of blindness over 65.
Yes, particularly in whites, females, two forms. Dry atrophic and wet exudative. Dry more common, 90%, gradual loss. Wet less common, 10%, but causes most severe loss, 90% blindness.
Pathogenesis, dry as thinning, wet as new vessels.
Basically, dry thinning tissues, deposits, drusen, pigmentation changes, wet choroidal neovascular membrane, CNVM, grows from choroid under retina. Fragile, leaks blood fluid, damages tissue fast.
Risk factors.
Heredity, age, nutrition, smoking, big one. Hypertension, sunlight exposure.
Symptoms. Gradual loss, dry. Sudden painless loss, wet.
Typically, yeah. Common, distorted vision, metamorphopsia, wavy bent lines, shadowed central field, reading difficulty. Peripheral vision, okay, so not total blindness.
Ophthalmoscopy. Dry shows drusen, yellow spots.
Small yellowish deposits on Bruch's membrane from metabolic products. Also loss of pigment. Wet elevation of retin RPE with abnormal vessels fluid hemorrhage underneath, CNVM. Fluorescein angiography standard for wet type. Indocyanine green angiography also mentioned.
Management, cause unknown, vitamins for dry.
Causes unknown. Zinc antioxidant vitamins, A, R, B, C, mentioned for dry ARMD risk reduction slowing progression. Wet form traditionally treated with laser photocoagulation to seal leaking vessels. Doesn't restore vision, prevents further loss. Early diagnosis critical.
Monitoring the other eye. Low vision aids.
Amsler grid for monitoring second eye. Low vision ads help cope. Source explicitly states older treatments, TTT, PDT surgery, replaced by intravitreal agents.
Anti-VEGF injections are the main treatment for wet now.
Yes, bevacizumab, ranibizumab, pigaptinib, aflibercept mentioned, inhibit VEGF, reduce leakage growth. Risk of CNVM in second eye higher if large drusen plus hyperpigmentation present.
Macular holes. Defects in the central retina.
Causes.
Ocular injuries, age, sequel to inflammation. Vitreous normally attached to macula. Vitreous degeneration trauma, separate traction on macula, it's strongly attached. Elevation loss of layers. Can be partial, lamellar.
Or a full thickness.
Symptoms, vision loss, distortion.
Gradual vision loss, full thickness. Distorted, blurred vision.
Lamella.
Full thickness. Complete central vision loss.
Diagnosis, slit lamp.
Slit lamp, biomicroscopy, plus 78 plus 60D lens to identify edge. Lamellar. Sharp edge, no surrounding detachment, yellowish deposits at base, full thickness. Surrounding ring of retinal detachment.
Treatment.
Some seal spontaneously. Many require vitreous surgery to ease traction. Internal tamponade gas to close hole can restore useful vision.
Pigmentary retinal dystrophy, retinitis pigmentosa, RP. Slow, degenerative, bilateral, starts childhood.
Right. Often blindness mid-advanced age. Affects rod scones. Rods first. Starts near equator. Spreads posteriorly. Macula affected late.
First symptom is night blindness, nyctalopia.
Yes. Defective vision at dusk. Present years before pigment visible, reflecting rod degeneration, visual fields, concentric contraction marked in low light, early. Annularing scotoma. Progresses to smaller field, tubular vision, difficult navigation.
Central vision loss late. Cataracts can bring it on earlier.
Yes, central loss late, 50s, 60s. Cataracts common can cause earlier loss. Associated issues, higher glaucoma incidence, rarely keratoconus.
Ophthalmoscopy. Characteristic bone corpuscles.
Classic sign. Small jet black spots, spidery outline. Initially equatorial, then spreads. Pigment sheathes veins, never arteries. Pigment migrates from RPE decolorizing, choroidal vessels visible. Tessellated fundus. Spots near vessels hide them. Number varies.
Vessels become thin. Optic atrophy.
Retinal vessels, artery veins, extremely attenuated thread-like. Ganglion cells degenerate, optic atrophy sets in, increases. Disc primary optic atrophy characteristics, but wax-like yellowish, consecutive optic atrophy. Later, posterior cortical cataract obscures view.
ERG is key for diagnosis.
Yes. Markedly subnormal, extinguished very early, prognostic importance. Secondary RP, inflammatory sequel. ERG, only slightly subnormal unless advanced. Congenital syphilis can look similar, but pigment pattern usually atypical.
Nature is genetic. Inheritance patterns vary.
Abuotrophic, genetically determined. Majority recessive, consanguinity not infrequent. Occasionally dominant, milder. Exceptionally sex-linked. Poor prognosis. Pedigree needed for genetic advice.
Associated systemic syndromes.
Lawrence Moon Beetle Bardet. Obesity, hypogonadism, mental defect, polydactyly, Usher syndrome, deafness, cardiac conduction defects, apalipoproteinemia, treatment unsatisfactory, nothing has decided influence.
Variants, RP sign pigmento.
Same symptom progression, no visible pigment initially, probably early stage RP. Differentiated from congenital stationary night blindness, rare, hereditary, no signs, stationary, normal ERG.
Retinitis punctata albicans.
Allied. Same history symptoms. Hundreds of small white dots uniformly distributed. Stationary form exists, normal ERG. Progressive cases are atypical RP variants, subnormal extinguished ERG.
Angioid streaks. Dark brown streaks.
Yeah, anastomosing look a bit like vessels, but deeper, near disc, irregular contour, due to changes in elastic tissue of Bruch's membrane.
Associated with systemic elastic tissue problem.
Frequently. Skin, pseudoxanthum elasticum, arterial walls, vascular degenerative choroidal lesions common, CNVM macula. Associated conditions, Paget disease, Ehlers-Danlos, sickle cell disease.
Benign peripheral retinal degenerations don't cause breaks.
Generally don't threaten retina. Snowflakes, dotted white near aura. Paving stone degeneration, focal chorioretinal atrophy, common. Reticular pigmentary degeneration, honeycomb pigment equatorial. Peripheral microcystoid degeneration, all adults, increases with age, may predispose to detachment, very old.
But some degenerations are associated with breaks. Lattice.
Lattice retinal degeneration is important. Recognizable white arborizing lines, lattice pattern. Peripheral fundus near equator. Retinal thinning constant. Abnormal pigmentation often present. slowly progressive. Retinal tears, common, association with vitreous liquefaction traction.
Others linked to breaks.
White without pressure, pale areas, thought result of traction. Focal pigment proliferation clumping, equatorial aura, tear risk if TVD present. Diffuse chorioretinal degeneration, myopes, predisposes to holes. Chorioretinal scars, old inflammation prone to tears. Cystoid degeneration, again mentioned as predisposing and very old.
Retinoschisis, splitting of retinal layers. Senile form.
Senile retinoschisis, splitting in outer plexiform layer. Commoner hypermetropes, usually bilateral, lower temporal, slow progression. Causes absolute field defect, upper nasal. Macula rarely involved.
How to tell from detachment.
Differentiation. Absolute field defect. Immobility transparency of inner layer. No treatment unless progressive symptomatic detachment. Outer layer holes plus schisis, observed. Low risk progressive detachment. Schisis plus regmatogenous detachment. Surgery, buckling, vitrectomy.
Juvenile retinoschisis.
Hereditary, splitting in nerve fiber layer, often with breaks. Cystoid changes fovea, petaloid pattern.
Okay, let's delve into detachment of the retina. Definition. Separation of neurosensory retina from RPE.
Exactly. Separation between neuroepithelium and pigmentary epithelium. Subretinal fluid accumulates in this potential space from primary optic vesicle.
Classification. Regmatogenous, tractional, exudative.
Based on mechanism, yes, clinically.
Yeah.
Secondary, obvious mechanical cause, exudative traction from other disease, versus regmatogenous, retinal break primary event.
Secondary detachments. Retina pushed away.
By fluid, blood choroidal hemorrhage, exudate choroiditis, retinopathy, toxemia, may reattach if exudate resolves, or neoplasm, choroid tumor lifts retina, causes transudation, gravitates lower.
Or pulled away. Tractional.
Right. By contracting fibrous tissue in vitreous, plastic cyclitis, proliferative retinopathy, ROP, prognosis not as good.
Regmatogenous means break.
Greek regma, break. Tear allows fluid from liquefied vitreous to seep through renas, separates neurosensory retina from RPE. Commonest type,
Finding the break is key.
crucial. Often hard to find. Presence of break, regmatogenous. Cure depends on occluding it. Shapes, round holes, horseshoe tears, flat pulled by vitreous, commonest periphery upper. Retinal insertion, dialysis.
Tear at dialysis.
Extensive tears, quadrant 90 degrees, giant tears. Dialysis, its insertion from ora serrata, large knock choroid visible.
Pathophysiology. Always due to break. Fluid from liquefied vitreous.
Always due to break in regmatogenous. Fluid from liquefied vitreous seeps under. Healthy solid vitreous detachment rare. Fluid partially detached vitreous, especially adherent to retina, traction with eye movements, detachment develops easily. Dynamic vitreoretinal traction responsible for most RRDs.
PVD plays a role.
Vitreous syneresis with age PVD. Strong vitreoretinal adhesions locally, partial PVD, pulls retinal tear fluid seeps under detachment.
Predisposing factor.
Myopia, previous intraocular surgery, aphakia, pseudophobia. Family history, RRD, trauma, inflammation. Retinal necrosis with breaks, ARN, CMV retinitis.
Clinical features. Shallow detachment, nonspecific initially.
Can be. Retina may retain function initially. First symptoms, sometimes transient flashes, photopsia, due to traction irritating neuroepithelium temporal field.
Then floaters.
Once break occurs, release of pigment small hemorrhage, floaters, small moving spots. Detachment extends posterior curtain veil obscuring field. Fall in visual acuity when macula detaches or large bullous detachment obstructs fovea.
Diagnosis and management. Careful exam needed. Indirect ophthalmoscopy.
Clinical picture characteristic, but shallow, difficult. Failure often from not doing thorough exam. Mirror exam, reflex difference. Indirect ophthalmoscopy, clearer, wider picture.
Appearance of detached retina.
Early shallow. Color relatively normal, eventually rapidly. Different tint, typical. White-gray folds, bright sheen summits, gray depressions. Slight eye movement, folds oscillate. Vessels over surface look darker. Extensive. Balloon-like folds. Detached retina, slightly opaque. Edema, normal choroidal pattern not seen. Convex configuration, moves freely unless PVR.
Total detachment.
Funnel-shaped, attached to scora serrata. Later, bunched behind lens. Disturbance nutrition, complicated cataract view, impossible.
IOP usually lower. Pigment in vitreous.
IOP usually lower, reversed by reattachment, rarely higher. Pigment in anterior vitreous, tobacco dusting Schaffer sign, usually present after tear.
Long-standing changes. Fixed folds. Cysts.
After months. Fixed folds, thinning, intraretinal cysts, subretinal fibrosis, demarcation lines, junction attached, increased adhesion, Buty fluid can spread beyond.
Proliferative vitreoretinopathy. PVR. Most common complication.
Yes. Growth cellular membranes. Vitreous cavity around retina, posterior vitreous face. Stages A, minimal to D, massive. Scar tissue traction, recurrence detachment even after successful surgery, disappointing visual results.
Identifying localizing breaks. Mandatory. Linkoff's rules.
Mandatory, often difficult. 50% one break, half in upper temporal quadrant. Linkoff's rules help localize breaks from detachment configuration, e.g., superior detachment extending equally down break near 12 o'clock, bullous is superior breaks break.
Prophylaxis. Treat predisposing breaks lesions. Laser cryo.
Yes, treat with cryolaser, especially with risk factors, symptoms, traction, trauma, myopia, family history, prior surgery, detachment, fellow eye. Lifelong follow-up essential, asymptomatic lattice with low-risk periodic review only, prophylactic laser, 2+ rows around tear.
Thorough exam is key for finding breaks.
Mandatory, time-consuming. Full mydriasis, indirect ophthalmoscopy, strong illumination. Scleral indenture helps see periphery. Goldman 3-mirror lens. Careful drawing needed. Examine in different postures. Accurate localization relative to outside sclera essential. Clock face meridian distance from aura.
Surgery. Only after finding all breaks.
Successfully performed only after accurate localization all breaks. Flowchart outlines approach.
Common principles of surgery.
1. Identify all break extraction. 2. Induce aseptic chorioretinal inflammation, seal breaks. 3. Release vitreous retinal traction. 4. Drain subretinal fluid. 5. Ensure chorioretinal apposition weeks via external and internal tamponade.
Tamponade options. External buckles, internal gas wipe.
Silicone buckle sponge attire encircling band. Internal air gases SF6C3F8 silicone oil. Components combined based on eye surgeon. Options made retinopexy, scleral buckling, vitreoretinal surgery. Goals. Identify closed breaks, minimum damage.
Cryotherapy laser for adhesion.
Induce chorioretinal inflammation around break edges. Cryo breaks blood-ocular barrier, stimulates RPE dispersion, TAPTER PVR risk. Adhesion takes 2 to 6 weeks. Cryo. Laser, less morbidity, prophylactic choice except very peripheral. Needs close apposition, 1 week. Cannot use if detached.
Pneumatic retinopexy. Gas bubble for superior breaks.
Fresh RD, single break group, clustered within 1 clock hour. Superior 2/3 fundus. Gas bubble intravitreally. Patient position so bubble tamponades break. Closes break, fluid reabsorbs. Laser cryo around break edges. Poor success. PVR grade B+1.
Scleral buckling external plumage. Silicone sutured disclera.
Yes, encircling band sectoral buckle sutured disclera. Indents eye towards detached retina. Relieves vitreous traction on break. Subretinal fluid drainage not needed if hole supported. CRA circulation okay. Extensive traction, multiple breaks, encircling band for circumferential buckle. Prophylactic and fellow eye for non-traumatic giant tear.
Drainage subretinal fluid, sometimes needed.
External sclerotomy or internal flute needle, indicated for bullous detachments, apposition difficult, or needing marked buccal elevation. Complications: choroidal hemorrhage, retinal perforation, incarceration, CNVM, endophthalmitis. Non-drainage effective, needs IOP monitoring. Non-drainage live fluid reabsorption, longer, elderly.
Vitreoretinal surgery for
Right.
PVR traction. Vitrectomy.
If PVR of vitreous traction causes persistent detachment, starts with pars plana, 3-port vitrectomy, remove axial opacities, vitrectomy plus remove vitreous from breaks, margins, vitreous base, peel segment membranes, PVR, internal fluid drainage through break or R, posterior retinotomy, retina flat andolaver around tears holes, long-acting gases, SF6C3F8, or silicone oil left for internal tamponade.
Gases, SF6C3F8. Expand. Last week's. No flying.
Inert, high MW, low solubility. SF6 expands 2.5x, persists 2x air. Higher surface tension than oil, absorbed weeks. Expand with pressure changes, NOS and O, flying non-pressurized aircraft with gas bubbles.
Silicone oil.
Yeah.
Advantages for complex cases. Complications. Removal.
Efficient tamponade, long duration. Dampens reproliferation, PVR. Complications. Secondary glaucoma, cataract, keratopathy, planned removal, 8-12 weeks. Faster visual rehab than gas, easier laser, valuable in advanced PVR, giant tears.
Complications of surgery itself.
Persisting detachment, macular pucker, PVR, recurrent detachment, diplopia, eon damage, anterior segment ischemia.
Prognosis. Untreated bad. Surgery success high anatomically. Vision depends.
Untreated unfavorable. Total detachment degeneration, cataract, iridocyclitis. Surgery anatomical success 95%. Visual prognosis depends on macular detachment duration, PVR presence. Poor if breaks large multiple, severe PVR, high myopia detachment 9 months. Most important failure cause: proliferation, contraction membranes, PVR. Buckling alone, pre-vitrectomy reattachment 47%. Now combined with vitrectum oil, most reattached. Visual results sometimes disappointing. Without oil, minus a 50% chance, 2400 plus FTNE. With oil complex cases, minus a 20% chance, 2400 plus after 30 months. Perception of light anatomical success may improve function. Risk in fellow eye. 15% phakic, 13 aphac pseudophakic.
Okay, briefly on congenital abnormalities of the retina. Congenital pigmentation.
Small oval gray spots, polygonal grayish black spot groups, flat below vessels unchanged, congenital heaps of RPE, benign.
Metilated nerve fibers. Myelin extends onto retina.
Normally stops behind lamina cribrosa, occasionally patches myelinated before lamina, ophthalmoscopic, white patches, radial frayed edges, usually contiguous with disc, occasionally isolated near disc, cover vessels, and large blind spot or scotoma. Rarely large, involve macula, abolish central vision. Degenerate, glaucomyoptic atrophy, disappear. Selective disappearance in MS melody, diagnosed, correctly not exudates, frequent bilateral, not strictly congenital, myelination completes after birth, no treatment.
Coloboma and albinism referred elsewhere. Phycomatosis, group of diseases, CNS retina involvement.
Familial, congenital basis, tendency for neoplasia, see ins elsewhere. Retinioptic nerve may be involved.
Angiomatosis of the retina, von Hippel-Lindau disease. Rare familial, manifests third, fourth decades, frequent males. Cerebellum, medulla, spinal cord, kidneys, adrenals also affected, angioma cysts. Ocular lesions, often bilateral, slow progression, may precede fatal cerebellar lesion, 10-15 years. What do you see in the eye?
Ophthalmoscopic, seriable, most common. Great tortuosity dilatation vessels, peripheral retinal angiomas, large balloon-like or small miliary. Progressive, increased permeability, enormous exudate deposition, masses resembling coats, detachment frequent sequel,
Treatment.
unsatisfactory advanced early, cryolaser localized angioma beneficial.
Tuberous sclerosis, Bourneville disease.
Young individuals associated CNS skin nodules, adenoma sebaceum. Similar nodular mulberry tumors, retinal astrocytomas in retina, near optic nerve, cerebral lesions, epilepsy, mental deficiency.
Neurofibromatosis von Recklinghausen.
May be associated with similar tumors in retina. Referred elsewhere for details.
Hereditary dystrophies of the central retina and choroid. Posterior pole, bilateral, symmetrical. Family history helpful.
Yes. Fundus picture, similar in family. Table lists diseases by site. Sex-linked juvenile retinoschisis.
Common bilateral dystrophy central retina. Fovea. Cystoid structure, radiating striation, superficial layers. 50% peripheral retinoschisis, inferior temporal, doesn't extend to aura. ERG subnormal, EOG normal. Splitting sensory retina, nerve fiber layer.
Stargardt disease.
Recessive progressive tape retinal dystrophy central retina develops 8-14 years early. Fovea normal, advanced. Beaten bronze atrophy fovea, whitish flecks surround atrophy, overlaps fundus flav maculatus. Final, extensive chorioretinal atrophy, posterior pole, poor vision, dark adaptation, ERG, EOG subneural, field slightly restricted, fluorescein, dark choroid, common. Final result, disappearance, visual elements, RPE center, vision drops rapidly below 612, stabilizes 660.
Inverse retinitis pigmentosa.
Bone corpuscles, peripheral, periphery normal. Progressive neuroepithelium, RPE, degeneration, marsh general atrophy, autosomal recessive usually.
Progressive cone dystrophy.
Dominantly inherited bilateral progressive VA loss, extreme photophobia. Central scotoma, color vision absent, primary cone dystrophy, ophthalmoscopy, moderate foveal change, or bullseye depigmentation later. Cone ERG reduced absent, rod ERG normal, EEG unaffected.
Leucoteliform dystrophy of the fovea, Best disease.
Dominant. Sharply delimited bilateral orange-yellow disc fovea, fried egg. VA good initially. Serious loss after transition to a regular pigmented, scrambled, or atrophic lesion. Leads to polymorphous foveal dystrophy. Disc in RPE, viscous material, fields normal except central scotoma, dark adaptation, ERG normal, EOG definitely pathological, most confirmatory.
Fundus flava maculatus.
Fleck dystrophy, bilateral, third, fourth decade onset. White yellowish fishtail, flecks deep retina, fuzzy outlines. Posterior to equator only, 50% macular involvement, most central vision falls. Dark adaptation, ERG normal, EOG mostly pathological. Histology, primary RPE abnormality, leukofusin. Now considered part of Stargardt disease.
Hyaline dystrophies, Doyne honeycomb, Hutchinson-Tay choroiditis.
Enzymatic defect RPE. Tiny round white flecks posterior pole. White colloid bodies, nasal side disc pathognomonic. Seen 20-40 years, initially asymptomatic. Colloid bodies increased coalesced VA, disturbed, advanced. Central scotoma, dark adaptation, ERG, EOG, normal fluorescein, multiple round fluorescent spots, drusen. Histology. Colored excrescences on druses, absent deficient RPE over deposits. Inheritance, regular dominant.
Central areolar choroidal atrophy.
Affects posterior pole, 40 years. Progressive choriovessel atrophy, choriocapillaris, RPE, outer retina disappear. Central yellowish-white chorioretinal atrophy evolves. Central vision lost. Color vision affected. Dark adaptation, ERG, EOG mostly normal. Fluorescence, visible choroid, aberosis. Histology. Central chorioretinal atrophy, heredity, usually autosomal recessive dominant described.
Labor congenital amaurosis.
Blindness early infancy bilateral, coarseness nystagmus, some pupillary reflex, eventual pigmentary degenerative changes, fundi, may look normal initially. Common cause infant blindness, polymorphic lesions typical, small white spots, periphery pigmentation, pepper and salt, aggregate bone corpuscular dystrophy, optic discs pale, vessels attenuated, macula affected, ERG absent, EOD defective, juvenile form described.
Lysosomal storage disorders.
Tay-Sachs. 3 syndromes, lipid degeneration, foam cells, Tay-Sachs, Batten-Mayo effect, ganglion cells, CNS retina, Niemann-Pick general distribution. Tay-Sachs, ophthalmology recessive, common Jewish children, starts first year, healthy child, blindness, wasting, apathy, idiocy, death 1 to 2 years, ophthalmoscopic characteristic, round white area macula, cherry red spot fovea, later optic atrophy. Due to absent hexosaminidase, a distorted ganglioside GM2, heterozygote detected by enzyme assay, prenatal diagnosis possible. Cherry red spot shown figure 17.35.
Okay, now diseases of the vitreous. Anatomy first.
Transparent gel, clear optical medium, structural integrity, nutrient pathway, clear avascular, 80% globe volume, internal limiting membrane separates from retina, potential subhyalate space. Composition, 99% water, collagen fibrils, hyaluronic acid, hyalicides, mucopolysaccharides, hydrophilic gel, liquefies with agent salt.
Detachment.
Posterior lens surface, Youth-Weigert ligament, very strong at vitreous base,
Yeah.
around ora serrata,
Yeah.
weak at optic nerve head, peravascular, weak oval attachment paramacular area,
All examination.
anterior vitreous with slit lamp, 45-degree slit, maniacal, observe cells, opacities, movement settles opacities rise into view.
Changes in the vitreous with age.
Cloquet canal, primary vitreous, lens to disc at birth. Secondary vitreous liquefies, shrinks, syneresis, 40-70 years earlier might.
Yeah.
Liquefaction, syneresis, mass shrinks, collapses, separation from retina, PVD,
Floaters.
condensations, vitreous fibrils, and liquefied vitreous, visible as floaters, mucosae volatiles, against bright background, various shape sizes.
Vitreous detachment. 3 forms.
Posterior basal anterior, posterior vitreous detachment, PVD, posterior to vitreous base. Senile, common or diabetics, earlier myopes. Spontaneous, sudden onset photopsia, vitreoretinal adhesions irritated, temporal field, and floaters.
Eye-searing.
Patient complains of ring-like opacity, Weiss ring, attachment to optic nerve head edges. Upper vitreous collapses first. Low retinal complication incidence. Benign unless associated with retinoschisis, RD, diabetic retinopathy.
Sure.
Careful exam needed, major reassurance if clear.
Anterior and basal vitreous detachments.
Secondary to trauma, often with vitreous hemorrhage.
Opacities in the vitreous. Annoying floaters.
Extremely annoying. Cast shadow, black spots moving. Mistaken for insects, Musca volitantes. Most compressed cell strands clumped. Causes
Developmental.
cloquet canal remnants.
Degenerative changes.
Asteroid hyalosis,
Mildew.
Shuri, unilateral, spherical disc-shaped white bodies attached to collagen fibrils, calcium-containing lipid complexes may be seen in diabetes, unilateral majority, asymptomatic but hinders view, rarely needs treatment, vitrectomy if vision affected.
Synchesis scintillans.
Degenerative, cholesterol crystals deposited, can be anterior chamber, subretinal space, affects damaged eyes, trauma and inflammation history, multicolored glittering particles, settle inferiorly, thrown up by eye movements, shower of iridescence, vitreous liquefied, no treatment,
Amyloid degeneration.
rare systemic, heredofamilial dominant, amyloid deposited collagen fibers, organs, systemic symptoms, ocular, diplopia, vision diminution, ophthalmoplegia, vitreous opacities, retinal hemorrhage succedates, bilateral, vitreous opaque, earliest lesion retinal vessel wall invades diagnosis biopsy for vitreous opacities linear with footplate attachments, diagnostic feature. Treated surgically, vitrectomy, prognosis guarded recurrence.
Other causes of opacities.
Senile and myopic fibers, vitreoretinal degeneration syndromes, inflammatory cells, cyclitis, hemorrhage, migratory RPE cells of the whole, capillary endothelial cells, adherent to retina AND producing symptoms, photosapodema hemorrhage. Traction likely to cause Brake's detachment.
Preretinal or pyretinal membrane. Macular pucker.
Lines interretinal surface, thin, cellophane, thick, sheet, contracting retina wrinkles, macular extramacular pucker. Threatens central vision, metamorphopsia, removed by vitrectomy with membrane stripping. Commoner older people, often bilateral asymmetrical. Surgery effective, cataract unavoidable risk.
Signs of traction.
Peripheral, white without pressure, or detachment, U-tear with operculum. Posterior, edema, hemorrhage, macular cystoid changes, heterotopia macula, tenting retina.
Persistent hyperplastic vitreous, PHPV. Congenital.
Failure of primary vitreous regression.
Yeah.
Shortly after birth, unilateral, white pupil, leukocoria. May associate with cataract, glaucoma, long ciliary processes, microphthalmos, hemorrhage, retrolental tissue contracts and pulls ciliary processes inwards. Later lens opaque glaucoma. Diagnosis, ultrasound CT, early stage. Aspirate lens, excise membrane, vitrectomy. Visual prognosis poor.
Posterior form.
Persistent hyaloid artery with large stalk from disc. Advanced extensive tractional detachment, little can be done.
Vitreoretinal degeneration. Wagner disease.
Autosomal dominant bilateral. Fundus, narrow sheath vessels, pigmented spots, periphery along vessels. Choroidal optic atrophy, vitreous liquefied with condensed membranes, adolescence. Vitreous shrinks, if attached to tear. Cataract late, extensive liquefaction central posterior vitreous.
Management. Stickler syndrome.
Regular exams, tears, laser cryo, severe traction vitreoretinal surgery, Stickler-Wagner, Stickler syndrome, variant Wagner, autosomal dominant connective tissue disorder, ears, eyes, joints, stiff painful joints, cleft palate, deafness, ocular, progressive myopia, spontaneous RRD, cataracts, blindness, frequent first decade.
Goldman for vitreoretinal degeneration.
Recessive bilateral familial progressive vision loss. Retinoschisis, central peripheral pigmentary degeneration, RP-like, followed by cataract, RRD. Pigment changes mark E or G extinguished. Vitreous liquefied, no satisfactory treatment.
Vitreous hemorrhage. Blood in the vitreous.
Manifestation of posterior segment disease. Localized, preretinal, subhyaloid, intravitreal at both. History. Sudden onset floaters, vision fall.
Examination. Settles inferiorly.
Careful vitreous exam, indirect biomicroscope, especially superiorly with indentation, look for tear. Hemorrhage settles inferiorly, reasonable view superior retina, often possible.
Appearance.
Preretinal subhyaloid, blood unclotted, moves with gravity, boat-shaped. Blood in lacuna tends to separate. Blood in gel clots, moves bodily. Long-standing blood loses color, settles inferiorly. White opaque condensation.
Ultrasound helping.
D-scan helpful.
Clear.
Fresh intravitreal scattered point echoes. Sedimentation flat sheet echoes. PVD echoes in gel OR retrohyaloid space. Fibrovascular membranes detected. Diabetic traction detachment. Angular retinal elevation. Immobile dynamically.
Common causes.
PDR, most common. Retinal tears, BRVO, retinal vasculitis, peripheral neovascularization. Trauma commonest in young.
Management.
Early surgery, traumatic etiology, or associated RRD. Other causes managed conservatively. Blood clears, discovered trait cause. Non-clearing, 3 months. Vitreoretinal surgery considered IF electrophysiology, functional ND ultrasound indicates reasonable anatomical success chance. Early treatment if fellow eye similarly affected.
Specific causes. Vitreous hemorrhage and retinal tears.
Tears crossing blood vessel. Myopes, predisposing degeneration, flashes floaters before hemorrhage, precipitated by mild trauma.
Vitreous hemorrhage and PVD.
Bleeding with PVD due to retinal traction. Vitreous gel or R preretinal, sinks lower, usually clears spontaneously. If tear is seen, treat immediately.
Vitreous hemorrhage and retinal vein occlusion.
Venous obstruction. Prone and hypertensive arteriosclerotic bloats, collaterals form 3 months post-occlusion. Microaneurysms, fibrovascular proliferation, bleed, photocoagulation reduces risk.
Vitreous hemorrhage and Eales disease.
Idiopathic inflammatory peripheral vasculopathy, recurrent vitreous hemorrhage, young males. Hypersensitivity to tubercular proteins, peripheral vasculitis, obliteration, hypoxia, vasoproliferation. Vasculitis sheathing, leaks, hemorrhages, exudates junction zones, later. Obliteration, shunts, neovascular shunts. Recurrent hemorrhage organizes tractional ROD, glaucoma. Steroids, aneurysm, note, laser traction, surgery mark traction.
Vitreous hemorrhage due to sickle cell retinopathy.
Sickle cell C disease ocular manifestations, see earlier section. C fans bleed.
Vitreous hemorrhage due to ocular trauma.
Young, contusion or R perforating injury. Usually intravitreal, clotted. Exclude foreign body, exam, x-ray, ultrasound, remove if present. Open globe injury, immediate repair, hemorrhage tackled 10 days later, PVD makes surgery easier. Concussion vitrectomy postponed 3 months for clearing F, no RRD, and the ultrasound clear. Early surgery advised with RRD. Foreign body shown Fig 17.38.
Lastly, vitreous surgery. When is it needed?
Vitreous opacification or vitreoretinal scar tissue development causing problems. Common indications listed in Table 17.4. Anterior posterior segment.
Like
vitreous hemorrhage, long-standing. Diabetic complications, tractional RRD, complicated RRD, retinal membrane fibrosis, injury plus foreign body, macular hole, endophthalmitis, complications prior surgery, cataract complications, opacification, associated with RRD surgery, PVR, giant tears, macular holes, tractional detachment, epiretinal membranes.
We have certainly traversed a vast and complex landscape within the confines of this single medical text excerpt. From the cellular detail of parasite loss and diabetes to the macroscopic mechanics of retinal detachment and the intricacies of modern vitreoretinal surgery.
Absolutely. It's been a true deep dive, pushing into every topic and concept presented here, aiming for that level of understanding professionals would require. We've seen how interconnected systemic health is with the eye, how tiny structures like the foveola are critical, and the multifaceted challenges of repairing and managing disease in such delicate tissue.
And reflecting on the sheer volume of detailed pathology, the different ways things can go wrong, and the, increasingly complex surgical and medical interventions required,
Yeah.
often with outcomes that, while anatomically successful, can still fall short visually. What does the very existence of these incredibly detailed descriptions and challenging treatments in this text tell us about the remarkable complexity and inherent fragility of our visual system, and perhaps the persistent gap between simply reattaching tissue and fully restoring function once that delicate balance is profoundly disrupted?